Dr. Tennille Paulsen is an emergency room physician who works on the front lines at a local Ontario hospital and also serves as a doctor in the Ministry of Community Safety and Correctional Services. She joins us now to share a critical perspective on the current practice and possible expansions of medical assistance in dying and the impact it could have on Canadian communities, doctors, and inmates. Welcome to 100 Huntley Street, Dr. Paulsen.
Thank you very much for having me today.
So for a lot of Canadians, there's also a lot of confusion around palliative care, DNR, like do not resuscitate orders, and medical assistance in dying. A lot of Canadians tend to blur those three options. They're not quite sure. Can you clarify those three different terms for us?
Yes, absolutely, because I do see that in the emergency room often, is the confusion kind of between the terms. So do not resuscitate is like a medical order or a decision where if your heart was to stop beating naturally or you were to stop breathing naturally, we would not attempt to bring you back with resuscitative measures. And that includes CPR, which is chest compressions, putting a breathing tube down your throat to help you breathe, and defibrillation, which is shocking. So typically, that order is agreed to in sort of an elderly patient or someone who's quite unwell, and that, you know, if your heart was to stop beating naturally, the likelihood of restarting it again would be very low. So that's what a do not resuscitate. If everything was to kind of stop, we aren't going to attempt to bring you back.
And then palliative care is something different as well, to do not resuscitate and M.A.i.D. What's palliative care?
It is. So palliative care can actually speak to any process in the course of an illness, but palliative care is symptom management and support. So making someone feel comfortable, whether they're being treated for cancer or at the end of their life. And so that is, and it's an agreement that, you know, we would help control symptoms. So typically in the emergency department, palliative care is referred to more as someone comes in and they are likely at the end of their life. Death is somewhat foreseeable, and we're not going to necessarily do life-prolonging treatment. We're going to treat your nausea, treat your pain, treat your anxiety, and all those things. So we're not extending life and we're not shortening life. It's just symptom control. That's what palliative care is.
And so then when we turn the corner to medical assistance in dying, or also known as M.A.i.D, and euthanasia in Canada, what is that then compared to the other two?
Yeah, so medical assistance in dying is a physician actively ending a life, either by giving medications themselves, or in some instances, patients can self-administer under a physician's guidance. So that would be the difference in the three. So do not resuscitate is if, again, just to recap, is if your heart was to stop beating naturally, there would no be resuscitative measures to restart it. And then palliative care is helping with symptoms and feeling and being comfortable. And then M.A.i.D is actively ending someone's life. And we know kind of all the rules and ethics around that.
Thank you, Dr. Paulsen. I think the clarification you've offered is so helpful to many of our viewers watching, and it helps equip us and helps us to understand what's happening when we talk about medical assistance in dying. Now, as a practicing physician yourself, you know that medical assistance in dying at this stage has been currently offered to those whose death is foreseeable, and now to those who have a disability. How does this make you feel as a physician? What do you think about M.A.i.D in Canada?
Generally, you go into medicine and, you know, the classic medical school interview is, you know, why do you want to be a doctor? It's, I want to help people. And that's, you know, that's how you go in. And so the focus in training and everything else is actually in sort of helping people. And it is a little discongruent with kind of all of our training and practices. And when you graduate, you say the Hippocratic Oath, which a proportion of it is primum non nocere, which is but first do no harm. And so there's probably a lot of conversation that could be had further around this topic. If you think about Jesus and the way that Jesus lived and walked, like he came to heal the brokenhearted, he came to, you know, make blind eyes see, and all the focus is on life, and I've come to bring you life and that you have it more abundantly. So as a faith-based physician, it doesn't it's not congruent with the way that Jesus lived and the way that Jesus walked. I think things do come into our culture that aren't the way that Jesus lived. And I think it's important to have a voice in our culture and to speak up for things that we don't feel are right. I think it's also important to remember as well, I was saying earlier, like we can, wave signs and write our politicians and different things when we don't agree with what our culture is kind of bringing into normalizing. But we also can't forget that, who is on the other side of M.A.i.D? It's people who don't have any hope and people who just feel very hopeless in their life. And so I want to, remind everyone that it's just as important to bring hope wherever we go, to live out your faith wherever you go, whether you're at your kids' soccer practice or, church on Sunday or the community center or your workplace, that, we want to be bringers of hope and counteract that side of things and not forget about the people that are involved. Yeah.
Dr. Paulsen, those are such insightful thoughts, and I'm so thankful for all you've shared with us today. Thank you for being with us.
You're very welcome.